for next month. But again, thank you. Tonight, I'm really excited about tonight's agenda. We are going to be having some conversations really about how we talk about COVID at this juncture, and what kinds of things we need to be considering at this point in time, given what we now know about COVID, what we now think we know about what's ahead of us, and what we need to do to keep our community safe. And so the format is going to be somewhat different in that we'll have a panel. We will have the normal COVID update or public health department update, but we'll also have a panel discussion with community partners and with you also around how do we message, what are the key messages for our community, and how do we get those messages across, and how do we shift the norm that from where we are now to where we want to be in terms of keeping people safe, or people keeping each other safe. And so with that, I would like to introduce my a colleague, Nestor Castillo, who is another co-chair, either three of us, and I don't believe Greg Hodge is not with us tonight. He's the third co-chair. You want to say a couple of things?
Good evening, everyone. Happy to be here. Looking forward to the discussion later on.
Okay. So I'd like to turn it over to our public health department staff to provide a few updates.
I think it begins with Dr. Moss.
Thanks, Lauren, and thanks, Kimmy, and good afternoon, everyone. Good evening now. So briefly, where we are, case rate up to 10.9 reported cases per 100,000 residents per day. Test positivity up to 6.3%. Still getting over 3,000 reported PCR tests every day, and also several hundred antigen tests. So this information, I think, is still fairly good. Although it's not a complete picture of COVID, as you all know. We don't know we don't get home tests reported to us. 86 people in the hospital today, 8 in the intensive care unit, 495 deaths in 2022. We're still in CDC low COVID community level, but we are seeing. Oops. There we go. But we are seeing increases in across all of our common COVID metrics. All these numbers are up, and the CDC community levels are heavily tied to hospitalizations, and so we may be in low even as we start to see further increases this fall and winter. Next slide, please. And so here's what the case rate has done over time. We reached a low point in October, and things are just have been trending up the last several weeks, still not anywhere close to where they were in midsummer. I don't know whether this is going to be a bump in the road or really the start of the fall and winter wave that we have been anticipating. Next slide. But we see this pattern when we look at different things. So this is test positivity. The solid blue line is county overall, and the orange line is in our most disadvantaged census tracts. So still fairly low, but going up. And we know that it's also been going up at some of our testing sites, which tend to have higher positivity, probably because they're serving higher risk people and people with who are actually sick, and so those people tend to test to have higher positivity overall. Next slide. Hospitalizations. So it seemed to move a little bit. I put a little dot here at the far right. We're actually this slide is already out of date. The hospitalizations are already back up where that dot is. And probably most of those hospitalizations early in a wave, we see hospitalizations go up with incidental COVID. People hospitalized for other things, but as there starts to be more COVID in the community, because everyone gets tested in the hospital, we start to see those increases in the hospital population. And then over time, we see more and more people sick with COVID. And we don't have that information in real time. It's a mix, but I think these early increases in hospitalization are probably just reflecting more COVID in the community overall right now. Next slide. Interestingly, our wastewater data was showing a trend to increase over a few weeks and has come down a bit. This can happen with wastewater data. It can be a bit noisy. So we're just going to keep our eye on this. I'm expecting to see further increases, but maybe this is just a bump and things will quiet down again. Next slide. Another important data point, this is actually from the state's dashboard, which very clearly breaks out bivalent booster uptake. And in Alameda County, we have had about 266,000 people getting the updated bivalent booster shot. So that's pretty good, but it's only about 19% of the eligible population. So a lot of work to do here. Next slide, please. This is switching gears to RSV. Some of you may have been following in the news. There's been an early RSV season this year. Sorry about the background noise here. We have RSV is a virus that circulates every year. And what you're looking at here is actually 6 seasons worth, 6 seasons of RSV. There was not much RSV during the first year of COVID. There was RSV last year in the yellow, but it happened at a bit of a weird time, but we did see RSV infections. And this year it's happening very early compared to past years. These are actually, this slide is showing RSV admissions to Northern California Kaiser facilities, not just Alameda County. This is part of the state's respiratory virus surveillance system, and they publish this information every week during the fall and winter seasons. And maybe a little bit of flattening out, but it's early, and we know that this has been the story across the country. An early RSV season that has resulted in some very busy healthcare facilities in some places. So we're following this issue closely. Next slide, please. And the other thing that is circulating is influenza. This is from the same weekly state report. This is influenza activity in California counties. And you can see Southern California with pretty moderate and even high levels of flu transmission. Not as much in up here in Northern California, but there's some, and it is going up. We're seeing evidence of that. So we have COVID starting to circulate. We have RSV circulating. We have flu circulating. There's also other common respiratory viruses circulating, and it's important for people to be aware that these things are out there, and if you're out and about, you are likely to be exposed. Similar to in the pre-COVID times, we all used to get those seasonal colds, and some of us may be getting the flu every year. We're back to that, and it's a bit earlier than what we normally see. Next slide, please. The good news is that really it's the same. We're asking people to do the same things to keep themselves healthy and keep other people in their lives healthy. Doesn't really matter whether it's RSV, flu, or COVID. It's a pretty similar rule book. Stay home when you're sick. That protects other people in your life from being exposed. Stay up to date on vaccinations for COVID-19 and for flu. Really important. Anybody over 6 months of age is recommended to get a flu shot. That it's effective. Early information suggests it's a good match this year. And just a real important tool. There is no vaccine for RSV yet, but maybe in a future season. As we've learned over the last few years, keeping gatherings small and well ventilated or even outside is a good way to keep them safer. Masks work great for all of these things. Protect you, protect other people. Test for COVID if you're sick. But even if you test negative for COVID, if you're sick, please stay home until you're feeling better. And of course, for COVID, real important to have a plan to get treated, as we're seeing more and more COVID about, particularly those people who are at higher risk. And just think about how you're going to get a hold of COVID treatment if you do get it. Next slide, please. I wanted to briefly update this group on where we are with COVID emergency declarations. We touched on this last time. First of all, the national COVID 50-state disaster declaration remains in place, and the national public health emergency remains in effect. And that we recently learned is going to be in effect at least until April of 2023. The state announced plans to lift the California emergency declaration on February 28th. That is likely when we expect things to be improving from the winter, although very hard to predict the future. The Alameda County local health emergency remains in effect as we're looking at another COVID fall and winter wave. And we'll see how things go this winter. We do intend to align with the state's timeframe for lifting as local conditions allow. Next slide, please. And that was my last slide.
All right. I'm going to go ahead and continue from there. So as Dr. Moss mentioned, we are expecting infections to rise again in the coming months. So our COVID division has been working on surge planning activities. And as you heard, again, Dr. Moss saying, outreach and education is key. We want to make sure people are wearing masks, washing hands, staying home, all the same things that we've been doing for COVID and other respiratory infections coming, in the fall and winter. So, but we're really working closely with our community resiliency partners, as well as our single organizations on outreach and education to really reach unvaccinated and uninsured individuals in our communities. And for our COVID investigations, we are going to be continuing prevention, education, and information sharing. We've been really focused a lot on prevention and providing technical assistance with outbreak management rather than holding, the outbreaks. A lot of our facilities and businesses have a lot of experience now, so we really just support them as needed. And of course, we'll continue to focus on those settings that have the highest risk for severe health outcomes. And one thing that I've mentioned before is that we've really worked hard to cross-train many of our staff so that wherever the need is during this next surge, we'll be able to shift our staff to that to where they're needed most. And in terms of vaccinations, we're going to be continuing to partner with our community resiliency partners, our coalitions, and other organizations to do pods. And we have seen an increase in at-home vaccination requests. So we've shifted back to 3 days a week to provide that service. And as we've mentioned, we are also co-locating COVID and flu and continuing our school-based vaccination clinics through December. So those are some of our current activities to prepare for the surge, get people protected. And then in terms of testing and treatment, we're continuing to really focus on making sure testing is available, but making sure people that test positive get access to treatment and to therapies that are available. And again, link our uninsured and underinsured residents to telehealth resources that are available. Next slide, please. So in terms of our surge strategies, again, I talked about this many times before. We really always will prioritize those settings that are at risk for the highest consequence of severe illness. Leveraging staff, I mentioned that already. We will deprioritize our site visits, especially with our long-term care facilities, but we've also done site visits with other facilities where we really work with them closely. But when there's a surge, we'll deprioritize those visits, of course, and increase our technical assistance as we can. And in terms of vaccinations, I mean, we have a pretty small team, but we also have some really great vaccination contract providers who we can shift to wherever the greatest need is. So if people, decide, oh, we do, people, as you saw, Dr. Moss shared that the bivalent boosters uptake has been pretty slow. So if we need to shift and increase that service, we'll be able to do that pretty easily. And in terms of testing and treatment, we're going to do everything we can to make sure people have access to home test kits. We're providing those at our stationary sites, at our vaccine sites, or both vaccine and testing sites, as well as masks. We're also going to continue to increase distribution of those test kits where they're needed most. So right now they're pretty much being distributed wherever we are, but if it's needed in specific neighborhoods, we'll make sure we'll get those out there. And then we also have mobile vendors that we would then shift to serve the most high priority zip codes and where the highest case rates are, and for example, to serve our long-term care facilities. Next slide. And then this is work that we've been doing all along. I just wanted to share that we'll be continuing this as well. This is our community support team, as well as our inquiries line. We'll be going to continue to have staff that support that. And we're doing vaccination appointments still, isolation guidance, access to treatments, MPOX information, resource navigation. So all of that access to treatment is continuing through this next 3 to 4 months. And then the final slide, just wanted to share a little bit about what will happen after March. I mean, in the past, we've seen a decline in cases towards the end of February, March. So we are keeping our staffing as stable as possible through February and March. And then at that time, we're going to start looking at downsizing our COVID unit starting in March and shifting really from an emergency response to integrating our COVID response functions back into DCDCP, which is our Division of Communicable Disease Control and Prevention. We're going to continue working with our community resiliency partners, of course, continue with our community health education, but really, I think this is something we'll be talking about today that Kimmy mentioned earlier. Really, how do we start talking about changing social norms and really protecting our residents, and how do we get those messages out? And then, this is something that all of you have shared with us, is that we really want to start integrating more services at our direct service sites so that it's more of a one-stop shop for people, for residents to get the services that they need. So I think I'll stop there and we'll talk about this a little bit more today in this meeting. Thank you.
Thank you, Donata. I think it's Dr. Ayala and Dr. Dunn will give us the MPOX updates.
Is Eileen with us?
I do not see her.
Okay, let's just keep the show going. Next slide, please. I only have 2 slides for you tonight, and this slide basically tells the story of the outbreak. We saw the outbreak at its most serious during the summer months. And I might just comment that those were the months during which the Bay Area experienced the Pride celebrations, first in San Francisco and then later on in Oakland. But you'll see the height of the outbreak sometime in late July and early August. And right now we're seeing kind of, the outbreak kind of trickle out. It's It's still smoldering in Alameda County, and we'll continue to watch this very carefully. But we're hopeful that, we're going to see the end of this outbreak. We stood up, as most of you know, an emergency structure, an incident command structure, which is our way of kind of ushering resources for a quick and emergency response. And I think that strategy paid off for us. And because daily caseloads are very, very low, we have decided to take down that emergency structure. But we have been working over the last couple of weeks to facilitate warm handoffs to parts of the health department who could now really manage what's left of this outbreak. And what Eileen did here was she superimposed milestones across the kind of outbreak as you see here, starting with, the first Steamworks regional Mpox vaccine pod, which was early on, followed by initial engagement with the Oakland LGBTQ Center, which has been an incredible partner to the health department. And as many of you know, they continue to host Mpox vaccine events and clinics. And then we activated the emergency response structure sometime just before the height of summer. I don't know what's here, but it looks like the slide didn't reproduce very well. We did 2 very big vaccine pods in Oakland for Oakland Pride and Pride Fest in back-to-back weeks. We vaccinated over 1,000 Alameda County residents at those 2 events by themselves. And we have initiated a roundtable with gay, bi, and trans men of color. We're really interested in leaning into our relationships and really doing a better job being in consistent conversation with the LGBTQ community, generally speaking. Next slide, please. This is my last slide. We stand at about 242 confirmed Mpox cases in Alameda County. And as I mentioned earlier, cases are decreasing. And that's true not only in Alameda County, but in California and the United States. We will continue activities which include case investigations and contact tracing, provider and community engagement, education and vaccination. And we're really focused on trying to get first doses out there and then really following up with individuals to encourage folks to complete the 2-dose series. As you know, the Mpox outbreak has primarily impacted gay, bisexual men and other men who have sex with men in the Black, African American, and Latinx communities. And then that makes our outreach efforts and our community engagement efforts especially important. That's all I have for you tonight on the Mpox outbreak.
Thank you, George, Donata, Nick. Are there questions? I see there's one question in the chat, and I believe either Dr. Moss or Dr. Nilsson will answer this question about the portal for home testing.
Yeah, the question is whether whether we've thought about having a county portal for individuals to self-report home tests. And so we have considered this, and in fact, people can do this. Most of the large test manufacturers are able to provide a way to report your test results. It's not directly to the county, but we get that information. And some people do report, but the numbers are very small. a county portal might increase those numbers, but I think based on what we've seen so far and what we've heard from other places, it would be would not give us a much more comprehensive picture. Unfortunately, we do have other tools that have proven pretty good at showing the trends. So, I agree more information is better, but I think that, we already get some of this and we haven't seen enough to suggest that that the juice is worth the squeeze. But that could change.
Okay. Are there other questions? Dr. Rhodes put in the chat, Umoja Health has a QR code at the Umoja Health sites that allows reporting to the state via primary. So there are ways for people to report their results. Other questions? Okay, so we're going to shift to the second part of our agenda where we are moving to a panel discussion around how we keep ourselves healthy and safe moving forward. And so we're at this juncture where we're moving from an emergency response to a more normalized public health response. Public health is always responding to outbreaks of communicable diseases. Mostly people don't know that it's happening because it's happening in the background. And so with COVID, because it was so large, it was worldwide, it's a pandemic, it was all out front and center, and all the tools that we had at our disposal were pulled out and used to contain, to the degree possible, the spread of COVID and to prevent as many deaths as possible, to prevent hospitalization, severe illness, and so on and so forth. As time has gone on, things have started to settle into a more normal public health response. And so we will see fewer and fewer health orders as time goes by. Dr. Moss already alluded to the ending of some of the emergency declarations, but that does not mean that the importance of protection is over. COVID is not gone. It has not ended. But the way we approach it and the way we respond to it will change. We will have to adjust. We are adjusting already. And so this conversation really amongst all of us is to really talk about what's working now. What are the challenges? How are we able to help people to understand the distinction between a health order and you must wear a mask, and strong guidance that you really should wear a mask? How do we engage people in those conversations? How do we encourage people and support people in protecting themselves? What kind of services and resources do we need to make available to ensure that people have what they need in order to protect their families and protect their communities? And so that is the gist of this panel discussion that we're going to have. And we are going to hear from a few of our community partners. We'll ask them some questions and they'll respond based on their experiences in the community and the work that they're doing. And we will also invite members of the audience to also chime in and to answer some of these questions as well, so that we can all hear each other's thoughts about moving forward, what we're seeing, what we're hearing, and what we're all going to do together to keep ourselves, our families, our community healthy and safe in the months to come. And so I'd like to turn it over to Nestor Castillo, who will facilitate the panel.
All right, good evening, everyone. So yeah, we have a couple of panelists that we're gonna hear from who are part of our community resilience network and our community resilience partners, I should say, and community navigators. And I want to give them space to introduce themselves, and we can start with Serenity House. Nicole, do you want to say hello?
Good afternoon, everyone. My name is Nicole Gardner. I am the Community Outreach Coordinator here at Serenity House. I've been in this position since the COVID started, and I look forward to keep working toward helping keep our community safe with the vaccination pop-ups that we have on a monthly basis.
Excellent. Thank you, Nicole. And we also have Caroline from Tiburcio Vasquez Health Center.
Hi, good evening, everyone. My name is Caroline Season with Tiburcio Vasquez Health Center. I am the Director of Partnerships, also leading the effort with our Vaccine and Resiliency Grant with our 5 partners. Thank you to the Public Health Department. We are happy to be here and eager to share our perspective on our COVID efforts.
Thank you so much. And last but not least is Umoja and Dr. Rhodes. Dr. Rhodes, would you like to say hello?
Sure. Hi, everyone. I'm Kim Rhodes, founder and director of Umoja Health. Otherwise, my day job is as associate director in the center at UCSF, providing vision and direction for community engagement. And I'm looking forward to talking about some of the behind the scenes things that are happening in a structural way that have impact on how we as community who are willing to do the work are sometimes potentially stymied in delivering what we would like to be delivering. So thanks for the invitation to be on the panel.
Excellent. Thanks again to everyone for participating tonight and willing to answer some of these questions and maybe give us a little bit, as you said, Dr. Rhodes, of some of the behind the scenes work that is happening. We have 3 questions, I think, that we want all of our panelists to answer. And of course, welcome everyone here to answer as well. But we do want to give them space first to take a shot at the question before we open it over to the rest of y'all. So the first question is, please provide an introduction about what your COVID engagement, outreach, and messaging strategies have been to help communities protect themselves. What has worked and maybe what hasn't worked, if you would like to share that as well. Why don't we start with you, Nicole? If I saw you unmute, and then we can go in that order that we just introduced ourselves, and then we'll mix it up for the second question.
So, and I forgot to mention before, thanks so much for the opportunity for Serenity House to be part of this discussion. So what our COVID engagement began with Urban Strategies when they had us do a questionnaire of COVID, if individuals would be vaccinated, and if not, why. So at Serenity House, we would distribute meals twice a week. So we began to get a good relationship with the community, found out why they wouldn't get the vaccination. We all know they don't trust the government, not enough research, and they would ask if we had taken it. So my answer to them was, I can't tell you that something will work if I had not taken it myself. So in order to protect myself and the community members, I have to become vaccinated so I can help you remain the same. So we would distribute masks and hand sanitizer weekly, sometimes daily, to the community. We're surrounded by a large unhoused community, and with them being, as us being community partners that's trusted in the community, it kind of works out a little bit better when you gain the trust of the individuals that you're surrounded by. So what has worked for us is just being upfront and honest with the community, having the vaccination pop-ups every month, and just being here every day to give them some of the things that they still need to protect themselves. It's really no other a community-based organization in this area that is giving out the masks and the hand sanitizer to help keep our unhoused community safe, especially because a lot of them living in tents. So the hygienes and things we provide them kind of help. We constantly talk to them about, washing of hands and not sharing, things with people. So I think it's just based on the relationship that you develop and the trust and being willing to be here every day and let them know that, this is not something that they're just going through. We, as a whole world, is suffering from the COVID-19 pandemic. So thank you.
Thank you, Nicole. And Caroline, seems like you were nodding along with some of that around relationship building and trust. Do you want to jump in there?
Yeah, definitely. Definitely echoing what Nicole had mentioned. I think kind of a key part to our engagement and outreach in the community, it was definitely our team of promotoras. And so, I think if we're talking about messaging and messaging strategies, I think it was very helpful, during the pandemic, to relay information to community members, through this team of promotoras who are from the community. And so, it's kind of trusted members, trusted leaders, who are kind of there in the community with them at different outreach events. These are people who they're familiar with, who look like them, who speak the same language. And it was really effective in getting the information out there. They can, it's, a lot of times it's a one-on-one interaction. So they're able to engage and ask questions. And I think this is really key when you do find individuals and families who were resistant to the vaccine. And skeptical about the government, and skeptical about, trusting the vaccine and should they receive it or not. And so definitely agreeing with her there. Just a few things kind of related to Tiburcio Vasquez's experience with engaging the community. For us, it's kind of a two-level strategy where we did in-reach with our current patients and then outreach to the surrounding communities. So for our current patients, we did messaging in a couple different ways. We utilized our Well app to send messages related to the different campaigns that we were doing related to COVID testing and vaccinations. We expanded our COVID services to our different clinic centers. So this kind of helps with expanding the access, letting folks know in the community that there are different ways to access testing and vaccinations. And then we also hosted Zoom workshops. I think it was called Know the COVID Facts. And so this is where our clinic providers offered information about the vaccine, which really helped, I think, instilling more trust with the community in terms of vaccinations. And reaching out to the greater community, the surrounding communities in South Alameda County. As I had mentioned, our promotoras were kind of a key strategy in all of this. What we found that was really helpful was doing door-to-door outreach. As I had mentioned, the interaction with the community members one-on-one and giving them the opportunity to kind of voice their concerns and ask questions was really helpful. We also shared information at our weekly food distribution. So as you all know, during the COVID pandemic, when everything shut down, families, they were in need of a lot of basic needs, and our food distributions, the uptick that we have seen since the start of the pandemic has just grown tremendously, and kind of in response to those who have lost their jobs, decrease in like household income, and also multifamily, homes would come in to these food distributions. So it's kind of a great way to kind of have a captive audience to disseminate information there as well. And one of the things that we have been doing through our outreach lately is also distributing home test kits to make it more accessible for individuals. And so kind of beyond that, I think for Tiburcio, what has worked really, really well is just kind of partnerships, really partnerships. I think was and is still key to doing this COVID work. Kind of a few examples of the partnerships that we've engaged in during this time is working with the Hayward Fire Department to provide vaccinations to community members, partnering with Chabot College and Ohlone, utilizing nursing and MA students to help staff our COVID clinics when we were hosting COVID clinics outdoors, and individuals would come in large numbers for vaccinations. And then lastly, as I mentioned earlier, Tiburcio is one of 5 partners in our coalition grant, the Vaccine and Resiliency Grant, in partnership with Eden Church, Kidango, Ruby's Place, Hayward Area Recreation District, to expand vaccine access and community resilience activities throughout South Alameda County. And so just wanted to kind of highlight the partnerships were kind of a big part of our work to be able to have the reach that we did. So.
Excellent. Thanks, Caroline. Sounds like it was a robust effort. Dr. Rhodes, anything else that Umoja has done?
I sort of echoing some of the things that have been said with just a little bit of a twist. I mean, I think our engagement and our impact really has been more in the information that we've been doing on a weekly basis now, on a bi-weekly basis, really since August of 2020. And then also, standing up kind of some of the first pop-ups before I think people thought it was possible to provide the services in that modality. But I want to say the one thing that I think is very different about what we do in our weekly information sessions, we're looking at the same data, but because partners who are around the table and the different kinds of expertise that are at the table, we have an opportunity to interpret the data of communities of color. So while the general messaging right now is sort of like it's okay to get back to normal, we seem to have forgotten all of the things that we talked about at the beginning of the pandemic, where normal is how we got to the disparities and inequity that we're looking at right now. So going back to that, since we haven't changed the social, economic or political structure, those issues are still there. So as we move back to normal, it's important to actually think about, like, what does normal, going back to normal, mean who didn't have access to resources in the beginning. I want to echo the partnership pieces that have been highlighted. I really think, being a sort of a non-traditional provider, in that we don't really have brick and mortar, we don't have a clinic, we're really just showing up where our partners tell us we need to be. That means that we're reaching I feel like we're often in the nooks and crannies of people who really maybe have some kind of healthcare coverage during this stage, but are not accessing it or leveraging it. And so we are literally coming to them. I think we were one of the first coalitions to provide at-home vaccination, drive up to your place and deliver it right there. That's also helpful for people who either couldn't get out or didn't want to be vaccinated in public. I think I'm going a little unstable. I'm going to turn off my camera. And then the other aspect I would highlight is about how we show up. And like I said, because it's very non-traditional what we do, I think it throws people off a little bit. It's like, why are you here? Why would you be in my neighborhood? Why would you be in front of this liquor store? That effectively communicates very clearly, like, we're here because we actually care, because otherwise we, wouldn't be in this particular location. We would just keep going with the status quo, which is, a location or a brick and mortar. And then we also show up with no judgment. So we're really about helping people stay safe, less about just the vaccine. So if you're ready to get a vaccine today, we're here to provide that. But if you're not, we're going to talk to you about COVID being airborne and really saying it in ways that public health departments, and Alameda County got the closest out of anybody in the Bay Area, but nobody would really say it's airborne. And that kind of helps people understand, why would people be advocating for you to wear a mask, right? So we're just trying to help people understand so that they can make decisions, and giving them credit for having agency versus having to shift the message to make them feel good, or hide some aspects of what's been going on in the pandemic. And then no judgment. If you're not getting vaccinated, that's okay. How can we still help you? Can we give you some tests? Can we get you Paxlovid if you end up getting infected, right? So we're just effectively saying we're here for you regardless. We're just trying to keep you alive. And then the what we call the for us bias, or the FUBU approach, where the people who are serving you are from your neighborhood and or from an organization that you already know, which also I think is disarming, because it takes away this, what I think happens when people approach healthcare and don't feel welcomed, right? We're effectively saying the care is being provided by the community, that is your community wrapping its arms around you. And I think that piece is really important. And going forward, I think that should be really emphasized and highlighted in everything else that we do. UCSF does not provide a lot of resources for what I do. I say, we do it by taking the coins from the couch cushions. But when they do, we're not going to advance UCSF as the front of this effort to say this is this institution, because we already know that communities' relationships with those institutions are not always good. So I think we need to be ready to, as institutions, take a back seat on the messaging and stop branding it with our stuff. Instead, brand it with the community and develop it with the community. Last thing on messaging that kind of flows from that is the billboards that we've done and the BART cards that are riding the trains right now, all messages that were created by the community in a collaborative, a huge Zoom, coming together to say what messages need to be put out there for our communities. And then we put that up without the institutional branding. So it's just up there as a moja. It says, we put this together, we own this. And so I think that's another important aspect of how we're able to reach people.
Thank you, Dr. Rhodes. So, the thread that I heard in all three responses to that question was trust, building relationships, meeting people's needs, right? That this pandemic came for many of our communities in a crisis that already existed. And so, I think Pastor Arlene mentioned it in the chat, right, around participation in the food bank being equal to the numbers during the pandemic. So there's an existing need that needs to be met, and that it should be community serving community to be as successful as as it possibly can be. Before we move on to the second question, we did skip over a couple of slides that we just wanted to cover really quickly. Lauren, if you could pull those up. There was a Alameda County survey in 2021 that sort of tried to get at some of the barriers to vaccination, especially amongst BIPOC folks. And the biggest differences between respondents who were or weren't vaccinated were the concerns around the safety of the vaccine, trust in the federal government or Dr. Fauci, whether or not side effects were worth it, maybe some of those things that some of our panelists can sort of speak to around hearing some of those same things. Other major factors, for example, for Latinx respondents was whether or not other people in their community were getting the vaccine. So as we've heard already, those relationships go a long way. I think it was Nicole who was mentioning that, coming in and saying I've gotten the vaccine, or others, goes a long way. For Black African-American respondents, it was the cost, right? Whether it was going to cost folks anything or if it was going to be free to them. Next slide, please. And vaccinated respondents reflected a broader range of concerns that can be grouped into 4 categories that include factual, safety, effectiveness, principled. People have a responsibility to get vaccinated, pragmatic, whether you can get an appointment easily, having vaccines that are easily accessible, getting it for free in businesses or trusted institution schools. And then the final was the collectivist approach, info from other trusted sources, other people in the community getting vaccinated, concerns for family, friends, and loved ones, and concerns and motivations often differed by race or ethnicity, and so too should our messaging. Sorry if you hear some noisy chihuahuas in the back. There's nothing I can do to control them at this point. They've stayed. Next slide, Laura. And then this is just a little bit of, I think these are called word clouds from the door outreach conversations from residents of census tracts with the highest number of unvaccinated Black and Latino residents from September of 21 to June of 22. And so why did you decide to get vaccinated, and why have you decided not to get vaccinated so far? And the things that come up the largest are things that I think are most often stated, or what folks say most often. And so in the first, you'll see, why did you decide to get vaccinated? Job, school, family, health, further health, other things. And then why have you decided not to get vaccinated so far? Safety, waiting till later, need more info, don't trust the government, do not care, right? So those are some of the responses that we saw from just folks that were surveyed in the past. And so I'm curious to hear maybe from our panelists, how are any of those responses, is any of this surprising, or is this sort of similar to what you all have heard on the ground? And maybe we can start with Caroline first.
I think this word cloud is probably a great illustration of what we have been hearing. I mean, I think in general, when dealing in the communities that we're in, a lot of residents, they have issues that, they might not be documented, and just kind of a general mistrust, I think, of the government. We've also heard that because the vaccine's so new, kind of what are kind of the health, the side effects of it, is it safe? I think those are probably the more kind of popular responses that we've heard through our outreach.
And Dr. Rhodes, any reactions to the survey or to the word balloon cloud thing?
Not surprised by a whole lot in the survey. I think it's what's interesting, and you may know that around the time that the mask mandate was lifted in March of this year, we started collecting surveys about attitudes and asking about where people get their information. And I think what's interesting about your right-sided cloud about why have you decided not to get vaccinated so far, there's a lot of touch points around it. I see fake news, disinformation. I thought I saw one more in there that really speaks to social media, but it doesn't say social media per se. And I just wanted to augment that with the results from our attitude surveys, which really show that the top 4 sources of information were the TV news, social media, friends and family, and then public health or the CDC. And that people who were influenced by social media tended to, and in fact had exactly opposite curves in the trends of either believing that the pandemic was over. So those who were on social media were believing that the pandemic was over. Those on social media were less likely to get vaccinated. And so I think that, these word clouds are really helpful. It would be good to really see and crystallize where are people getting information, where they're thinking about, where fake news is the influence, and misinformation. All of that then generates this lack of trust. The other thing that I don't necessarily see there is, No, I just lost I just lost my thought. But to the biggest point, I think, is just that we need to ask ourselves, in terms of messaging, where do we need to be? Where do our messages need to show up in order for them to be absorbed? And what happens on social media is the messages are coming in such volume that it doesn't matter if you're dispelling myths, one by one. That's a waste of our time chasing that down to prove that it is wrong. We need to start to think about, how do we push back and battle back? And I think that is about numbers and the number of times that people see something. And I also think it's about being potentially on television in those spaces where people are really getting the majority of their information.
Thanks, Dr. Rhodes. Any reactions to the survey or the word clouds, Nicole?
Well, my reaction is basically the things that's on the word clouds are things that Paula and I would hear on a daily basis when we were doing the survey. But also, when the pandemic first started, it was not a lot of vaccination pop-up clinics in the Black and brown communities. So, a lot of them looked at it as if it's something that's affecting the whole entire state. Why are they not coming over here to see about us? So we have to think about, them feeling mistreated, because we can go to like San Leandro or Fremont or, East Oakland and get the vaccination, but it's not being offered here in West Oakland. And I think a lot of times, just because most of the individuals in our area are unhoused, they are seem to be uneducated, and that's not always the case. So the information that was being distributed elsewhere should have been distributed in our area. So when we were telling them about why they should become vaccinated, our success rate might have been a little bit higher if we had the information to back us up, as opposed to it just being our word of mouth. So I think, when we talk about subjects like this and give out information, we need to look at the whole picture. Is each individual community areas, are they being given the same information? So that was my struggle, the challenges of my work. But the success of my work is reaching that unhoused community that's over by St. Vincent, and the ones that are dropped off over here on a daily basis, and having a constant increase in numbers when we have our vaccination pop up. So the pros right now are outweighing the cons, and we're just trying to get as many vaccinated over here in West Oakland, where we are, and continue to give them information that will keep the trust not only in us, but as far as the government as well, with the information that we're able to provide. Thank you.
Thanks. I think you kind of are leading us into our second question, naming some of those successes and challenges of the work. Our second question is, based on your experience with COVID-19 health and promotion and safety, what are the unexpected successes and challenges of the work? And maybe we can start with Dr. Rhodes this time.
I would say one of the unexpected successes was actually the migration of the concept of Umoja to other counties. The willingness of other CBOs, just like we have here in Oakland, looking at this model and understanding that it is a way for something that is sustainable, that is not just about COVID, and that has the potential to, open up avenues for other kinds of public health type interventions and prevention work. And namely, I will point to our colorectal cancer campaign and the screening that we were able to do in the same kind of setting that we were able to offer vaccine and testing. Just makes you realize how much can be done outside of traditional settings, that again, with the embedding of community members as the providers, is sort of a recipe for sustainability beyond the pandemic. And I think that's so important, partly because it starts to change the culture of expectation of like where you can get healthcare and who can be providing it. But it also speaks to this idea, you know, we talk about trust like it's a destination, like once you get it, you got it. And I think anybody who's been married for a long time understands that you're building something over the long term. And like sometimes it's good and sometimes it's terrible. But the way you get to trust is really through staying there through thick and thin and kind of working through the parts that are hard. And so I think that is something that I think will carry on beyond the pandemic, although if it's like HIV and we're talking about this 40 years from now, like, I don't know. But I'm just saying like this acute phase that we're in right now, you know, I think everybody's all geared up to do the work, but the question is, how do you sustain that going forward? And I think the way to sustain it is to have the community be embedded in the solution and directly be part of the solution. And then the second success I just want to point to is the development of the Youth Mobilizers crew. And I'm still pushing, and this is a sustainability issue too, I'm still pushing that kind of workforce needs to be hired into our public health departments because they can do messaging on things besides COVID, including sexually transmitted infections, teen pregnancy, and issues like this, that where those voices are generally not heard. And I'm going to shout them out again for Gen Z for saving us in this last election and voting against crazy. Because they're going to inherit what we're making. And I think they're finally starting to realize that they actually need to exercise their full agency in order to have an impact. And so I'm really excited at how excited they are about getting the word out and about trying to influence people, because I think they can do it in a gentle way that is not off-putting, is not judgmental, and is peer-to-peer. And I think that, so I would say that the development of this workforce and the people who are committed to continuing to uplift the health of the communities that Umoja serves has probably been the biggest success.
And briefly, any unexpected challenges? Maybe there were a ton, but maybe one that is one that we can learn from and that we can sort of all think about?
Well, I mean, I think most of the challenges that I'm really focused on are structural. You know, I brought up in the previous meeting, I don't think I brought it up here, but like how difficult it is for someone who's doing a non-traditional kind of use of my medical license, right? Like serving people on the street, which I call like, that's real access, right? Like people just want a question answered. They don't want to wait 6 months for an appointment. And that's something that we've been able to provide. But the way that Umoja gets put together really is like very much patchwork, and it is a lot of a reflection on trying to understand systems and then work those systems. Like what can we do within the rules to allow community to be part of the solution? So I would say some of the big structural roadblocks to embedding community in the solutions is probably the biggest challenge, that if we could get over that, I think we could shift how people think about taking care of themselves and taking care of other people. And I just want to name that, you know, I really struggled, and Dr. Locke helped me out with some language that I can use next time, but calling in a prescription for Paxlovid. Like we're telling everybody we have the tools and we have access to these treatments, but if I, as a licensed physician, cannot call in a prescription to the commercial pharmacies that have really gotten a lot of, given the weight of distributing Paxlovid on a large scale, like then there's going to be a problem. And again, it disenfranchises specific communities. And I could, you know, name a number of different resources that we're able to finagle that have hoops that, you know, I'm required to jump through in order to get. I think those are the real challenges that I think we need to tackle in order to have a more facile way to have the public take care of the public health.
Great. And Caroline, any unexpected successes and challenges over at the Tiburcio Vasquez?
Sure. I'll start with challenges. You know, as part of the Vaccine Coalition work, a lot of it is focused on specific zip codes, specific areas where we find that the data is showing that a vaccine, that vaccine rates are low. And so as a part of our outreach work, while it's a great way to engage individuals and families, there are community members who repeatedly, deny and who are resistant to the vaccine. And I think that still continues to be a challenge to our work. And I think at that point, I mean, we're not there to necessarily sell them on receiving the vaccination, but I think at that point, it's really then kind of a public health response, where if they haven't received the vaccine by now, maybe the likelihood is very low. And at that point, we can just, suggest, different protective factors, encouraging wearing masks in public places and also in enclosed areas to protect themselves and their family. And so that kind of continues to be a challenge for us in doing our outreach work. One of the things that also was kind of highlighted for us during the pandemic was technology issues. I think when you're dealing with low income communities, access is affected a lot, and that way, the family's access to internet and to access Zoom, to log into any of these informative sessions, how to use a QR code. We had families who were still using flip phones. And so, we had to do a lot of, it wasn't so much, the promotoras are out doing health education, but we were doing a lot of, technical assistance almost, just helping them kind of access information, to have the same level of access to information as, other communities as well. So, we find a lot of our work is doing a lot of these multi-level kind of wraparound services where it's not just addressing the COVID bit, but it's really addressing, the person as a whole. If they need assistance with finding, housing or employment, and as I mentioned, basic needs, diapers, for mothers, it's our work kind of encompasses all of that to kind of help to link them to all of those different types of resources, and also using our partnerships to link them to, to other services and resources as well. In terms of successes, I think that, just as an organization, we're able to respond fairly quickly during the pandemic. A lot of our visits we were able to turn into, I think during like a 2-week period, turn a lot of our in-person visits into virtual visits, kind of for primary care. It was very important for our patients when accessing behavioral health care. I know that there was a huge need for patients to seek mental health, behavioral health care, and to access providers in that way to make it more accessible. And also going back to challenge, this also kind of also reminded me, when talking with community members, there was also a bit, we had to kind of talk through a lot of mixed messaging because some of the mandates were different from county to county. It was one of those things that we had to kind of talk through and explain. I think it was confusing for a lot of community members, like, do we mask, do we not mask, like, kind of what is, kind of what is the hard rule here in Alameda County. So that's kind of a part of the health education and the information that we had to disseminate during our outreach.
Thanks, Caroline. Nicole, anything you'd like to add around some of those unexpected successes or challenges?
No, just, I was waiting on more information, and now our organization works along with the Oakland Frontline Healers, so we're able to get more information to give out. Again, my concern was just not having the COVID vaccination pop up in our immediate area for a while.
Mm.
So the success is on Friday. It will be our 19th COVID vaccination pop-up here at Serenity House. So, you know, you have to go through the bad to get to the good sometimes. So thank you.
Yeah, definitely. This last final question, maybe we can our panelists can try to we can see if we could be brief so that way we can hear from others as well. And you know, I think I'm also gonna change it up a little bit. So the question is, what do you think that we as the public health department or as community partners can do to change social norms? And I'll add maybe even structures as well, right? That are sort of preventing these, you know, that sort of create the inequities in the first place in our communities and encourage protective behaviors going forward. What can we provide and what do we say, right? Especially, you know, if, for instance, if we're in a place where we see a lot of cases, right, during this winter, and we have to switch it up and go back to masking, right? Because a lot, you know, I'm out and about and not that many folks wearing their masks, right? How do we sort of encourage that messaging? How do we sort of begin to touch on those social determinants? How do we think about changing behaviors? So I'll open it up to whoever wants to take on this question first of any of our three panelists. Who'd like to start?
I'll just say briefly, this is not about structural issues, but I think, you know, because we are functioning in 3 different jurisdictions and we sit with 3 different health departments, I mean, I really can honestly say very clearly that Alameda County does a really tremendous job of respecting their partners and their partners' opinions in ways that, you know, is not happening everywhere. But one thing I would recommend is, and I think I had a conversation briefly about this maybe with Nitu about, for the coalitions, for example, which is a brilliant idea, to geographically cover the county, but the collateral that gets produced still says public health department. So we have community partners out distributing information for the public health department. It may erode the credibility of the partner, right? Because here you are pushing the government's information or the way people perceive like the government. But co-branding the materials, I think, is just like a very simple thing that could be done to, again, have the institution take a back seat. Yes, you paid for it. Yes, the resources were invested out of your pots of material resources. But if it feels like it's coming from community to community, I think that the shift is going to be easier than it being the public health department saying it's time to change the norms.
Nestor, I think we can also maybe invite others who are not panelists to also chime in to help, you know, answer this question and kind of, you know, think about, you know, what kinds of things should we be doing to help shift the norm? There won't be those mandates saying you must do this here and here and here. So how do we support community in keeping themselves safe when they need to? So it won't even be masking all the time year round necessarily, but how do we get that very nuanced kind of, okay, so, you know, when things are looking like this, you know, you really need to, you know, take extra precautions and keep your mask on or do that kind of thing. What kinds of things what kinds of things can we do, all of us together? Because it's not just about what the public health department is going to be doing. It's what we all are going to need to do.
It goes back to what was said at the beginning. Once they earn your trust and they trust and believe and know that you are being watched by the ones that are denying the COVID and all that, and they take and watch, like here, they watch us a lot. And so the more they trust in us, the more they have confidence in us. It goes back to the beginning of the survey we did. At the beginning of this meeting, you were asking the question, and a lot of people didn't trust the government. A lot of people didn't trust the doctors. They didn't trust the shots, and they thought it was all about money and this and that and other. And here we are on our 19th pop-up, COVID pop-up vaccination. And we have been able to have at least 80 to 90 people at each one of our pop-ups for the first vaccine or the booster or whatever. So it has to go around building confidence within, and for that fake news that was going around, we were able to talk to people about it, get their opinions. And now those people that did not want to get vaccinated is vaccinated, and also they come back for their boosters. So it's the confidence, the building of the confidence, within the community coming from you. It starts with you. Like you said, we don't judge. We don't talk down to them. We don't try to belittle them. And for that, a lot of that media, like Dr. Rose was talking about, a lot of the media has said things to make people not even want to look toward a vaccine. So it all starts within us. It starts within us. And the more we stand up and the more we stand out, the more people will start to come to, terms with being protected. Thank you.
Thanks. Gary, I see your hand.
Thank you. Yeah. So outreaching with the Umoja, I think, is very impactful. What we do is multiple messaging, right? So we just don't talk about COVID. We talk about prostate cancer, breast cancer, colorectal, right? Diabetes. We meet the people where they are, right? And so if there is an overload of information that is, causing, that COVID fatigue, well, how is your cancer, conversation, and then in the household, and we can meet them there. And a lot of people have those multiple chronic diseases in the households that gives us an opportunity to engage them on a one-on-one when we're out in the neighborhood. Now, so when we have information that is readily accessible in hand, that we're able to pass to them on these multiple chronic diseases, and then give them access to information through Umoja Health that can give them opportunities to invest in their personal health care through their, throughout the whole family and then the community. I think that's a very broad way to access the community, because again, the fatigue is rampant. Looking at the messaging on the BART and the freeway, our community, we're so tightly connected. People pass through multiple counties. If you ride BART, you pass through multiple counties, within 30, 40 minutes. But that same message is still appearing right there in front of them. And I think that's so effective. We have to look at our public health departments aligned in, their messaging. But again, how do we engage the community is much more important, because again, the trust factor is there. So that multiple messaging part is so very critical. And that's what's being engaged right now in the community via Umoja Health. Just wanted to point that out.
Thanks, Gary. Any other thoughts on what it is that we can provide as either as partners or as the public health department? Or I see Nicole, I see you. Go ahead.
Yeah, I just want to say, with Alameda County Public Health Department, I think they have been exceptionally well to Serenity House because when we contact them and let them know, hey, we're facing this problem, they're here to help. It's a true partnership. They meet us where we are within our community. So I think they're doing really good as far as I'm concerned, because not only do they listen to Serenity House, they come out and they listen to the voices of our community. So the public health department is great in my book. Thank you.
Thank you. Pastor Arlene.
Yeah, this may be unique to my being a pastor, but nothing in the clouds that were shared surprised me. I mean, I've heard all of that stuff, but there were some things that were missing in terms of like what people bring to me. And some of it might be termed spiritual or theological. I've encountered a large number of people who are resistant to the vaccine, who I would say have kind of a deterministic or fatalistic kind of sense of how the world works. And, it's like, if it's your time, you're just going to get it. You can't do nothing to prevent it. I mean, psychologically, I think people would talk about this as, folks not having a lot of sense of agency. Well, where did that come from? Well, a lot of structural oppression, for starters, right? I mean, there's just many ways that we could frame the experience, that holds people back or keeps folks from self-care, and so forth, So flip that around. I would say, one of the things that we can control, we can do, is we can speak affirmatively, for people of faith, from a faith tradition, wellness, wholeness. My tradition, we talk about, science as a gift from God, not as opposed to what God's doing. But also, I think, helping people to see themselves as actors in their own best interest and the interest of their families. My goodness, we deal with such a large number of first generation newcomers. I mean, these newcomers, I mean, they don't feel like they have, that they have hardly any control over anything, right? I mean, the government, immigration systems, my God, so oppressive, but to, create, moments in the sense in community that they could have any, any agency, that's, I don't know, there's an opportunity there.
Thanks, Pastor Arlene. Dr. Carey.
Hi, good evening, everyone. I think a comment and a charge for the Public Health Department. When early on in this pandemic, when it first hit, we knew that one of the things that came to light, which I think we already knew in our community, but was really obvious, was the low health literacy in our communities. And so as we're moving beyond this emergency response, I think it's important that we start to increase the literacy around health in our communities. One of the things that I do is I do a weekly health tip of the week, and talking about things that are not necessarily associated with COVID, diabetes, just like Brother Gary was saying. Diabetes, we talk about heart disease, we talk about nutrition, and just really trying to provide information to the community in a very simple, two-sided flyer that we hand out in some of the churches in West Oakland around that are doing food distribution in different sites. So we're trying to continue to increase literacy because we recognize that it was because of this health disparity that our communities were hit so hard, right? So trying to make up for some of that during this time. And then the second piece is that, one of the reasons why people were getting vaccinated early on was that they wanted to protect their children. And that was prior to there being a vaccine available for kids. And now I think with the abysmal rates of vaccinations in our children, that one of the, this is the charge part, public health department, is to develop messaging to help to vaccinate our kids. Right now, there's vaccines available for our children, and we don't have great messaging to parents to let parents know about the safety of these vaccines for their children, particularly for the youngest kids, right, the 6 month to 4 years old, who are probably going to be hit really hard this winter with the combination of COVID and flu. And so, you know, studies show that the two like to run together. And so it's going to probably be a pretty hard winter for our children. So messaging to parents around the safety of the vaccine and really trying to increase the vaccination rates of our youngest folks in our community.
Thank you, Dr. Carey. I'm just looking at the time here. I think we have to wrap up, and I just want to thank all our panelists, Caroline, Nicole, Dr. Rhodes, for participating and for all the comments that we received from everyone else. I think there was a lot to take away from this discussion. You know, I want to challenge all of us to think about not, you know, which is what I heard from all of you, is how we not only sort of promote that individual agency, but maybe that collective agency, right? Of how we can all do this together, and yeah, protect our communities, protect our loved ones, like we're all working to, and try to eliminate those racial and existing health inequities. And so I'll turn it over back to Director Watkins Start to close us up.
I want to thank everyone for the conversation, the questions, the challenge, the charge, and of course all the wonderful accolades. But of course, you know, we are a community, all of us together, and so we are doing this work together. There is no such thing as an effective public health department without a really good partnership with community organizations that are really on the front line, working with people who need to be reached. And so we're all doing this together, and we have a lot more work to do ahead of us. As you all mentioned, all of those health conditions that they didn't go away, they didn't take a break. You know, I think someone said, it might have been you, Dr. Rose, cancer didn't go on holiday, you know, when COVID hit. None of that stuff went away. And so we have to be thinking about not only how we continue to help people to protect themselves with COVID, how do we also leverage all of the successes that we've had, the different models we've tried, the approaches. I mean, I've seen a re-emergence of like activism and engagement around health that, quite honestly, I haven't seen in a while. You know, of course, we're in a pandemic, but let's get a good run out of this in terms of just the energy and how involved and engaged people are. All of you are, and those who are not, you know, in this meeting. And so we're going to keep having these conversations about what else can we try, lifting up the models, you know, that we know work, that have worked with COVID, and how do we then apply that to other things? We still have infant mortality that has to be dealt with. We still have HIV that still has to be dealt with. We still have chronic diseases, cancer, heart disease, diabetes, and so on and so forth that we still have to all work on as a community. And we've learned a lot from COVID, a lot. Now, how do we leverage this and take it up a notch and broaden our focus to really embrace all those other things as well, and test out some new models too, some new things. So like I said, this has been a wonderful space to be in, creative space, and I love working with all of you. We love working with all of you. Thank you so much for being here, and again for changing the time so that we can meet today instead of last week. And we will see you all next month. And I think next month is going to be kind of an evaluative conversation about where are we now with the CAG and where do we want to go moving forward as a group. And so kind of be thinking about, what's our next steps together. Thank you all and good night.
Test your guess. Thanksgiving. Peace
Right.
and blessings.
Thank you.
Good night, everyone.
Thank you, everyone.